So, thank you. So, essentially, I'll be talking about newborn surveillance for birth defects. My context is Pakistan, but I also believe that um, most of the scenarios and the learnings are really very applicable to most low resource settings. And that does not only mean low income countries, but there are pockets of extreme underprivilege in reasonably well developed countries as well. So perhaps this will help lend insight from our learnings to see how it can benefit others as we continue to develop our thought process. So it is certainly a work in progress, and these are thoughts rather than um, any directions of how things should be done. So, in that spirit, I'll get started. Hope to speak for half an hour and leave the rest of the hour for questions and answers, and also ideas on how
Hmm.
we should proceed with our work because it's a great timing. It's an inflection point of sorts. So here goes. Really, I'll be talking about um, first of all, let me get this and let me get this right. So again, all good work requires a lot of teamwork. We're very grateful to our partners from NTNU in Norway. Felicity Mehendele has been just amazing in helping me frame my thoughts. And our other Norwegian colleagues, the George Institute of Global Health in India, New Delhi, India, where Professor Nobojit Roy has been a faculty and has been a huge support in this journey, as well as my colleagues from the Aga Khan University in Karachi, Pakistan. Um, our team comprises a mix of doctors, epidemiologists, um, frontline field implementers. Shazia, who is my partner in crime, so to speak, Dunia, Dan, others know her well, is also a medical educator. So she has focused on health worker related education. And that, as you will see in the next few slides, has been a huge support for us. And then this absolutely wonderful group of women that we trained to conduct the newborn surveillance, who are really the strength behind all the work that we've done. So the way I want to structure the next half hour or so is to talk about our newborn screening for external congenital anomalies at selected facilities in Pakistan. This is the data that really has informed our work so far. And then do a few deeper dives into some key aspects. And then, if we have time, I would like to touch a little bit upon our study on access to healthcare for affected infants and how that impacted outcomes. And then finally, what next? And that's where I'd love to get your input. The next one really, so let's dive straight into newborn screening for external congenital anomalies. And just to extend my gratitude to Smile Train, which provided most of the funding for this project. Just to give a bit of a background, 8 million babies are born with congenital anomalies every year. A good proportion of them do die. Now, because of a combination of nutritional issues, environmental pathogens, consanguinity, intermarriages within families, lack of antenatal screening, um, leading to fewer terminations for major birth defects, cultural issues around terminations of pregnancies, and so on. The vast majority of these anomalies take place, occur in LMICs, and therefore most of the deaths also occur in LMICs. Because not only is the burden very high, there is a parallel challenge of not having health facilities that can cope with that burden. Newborn screening for anomalies is routinely done in most high income settings, but very rare in LMICs. But we do know that if we screen early and start intervening immediately after birth, a bulk of these deaths and disabilities can be mitigated. So with that in mind, we wanted to develop a contextualized curriculum for newborn screening for the health workers to lead the screening, train them in that curriculum, ensuring that screening is effective. But also there is a referral and a advisory role that they play for these health workers, because our public sector hospitals often don't have staff who know what to do when a baby is born with a major visible birth defect. And we wanted to establish a screening system for identifying external congenital anomalies, and finally to refer the identified newborns for care. Now, just a bit of a sidestep, the reason why we chose to focus on external congenital anomalies was because they are easy to identify, they don't require diagnostic testing or expensive on-site intervention, and has often been chosen as a good starting step in other countries, including India, for example. So we chose to focus on that subset of anomalies. This by no means decreases the importance of anomalies like critical congenital heart disease that often requires diagnostic testing, or hearing impairment, and metabolic birth defects like a hypothyroidism, and in some countries sickle cell, etc. But we chose to use this external congenital anomalies as the most feasible starting point. This was a cross-sectional study at 3 public sector hospitals in Karachi, chosen because of their high birth volumes, and conducted over a year. And the screeners were lay health workers. They were women from the community, young girls, older women, who were trained and then stationed at labor or operating rooms at these facilities, so that they had the ability to screen newborns almost immediately after they were born, with the consent of the family member who was with the newborn. So we used a curriculum that was learner-centered, with a component of classroom as well as on-site training, head-to-toe examinations of all consecutive births, and the cutoff we used was 28 weeks of gestation. Anomalies were identified and families were counseled. We used RedCap to capture data, and we had a group of experts that helped us review and validate the diagnosis that we were doing. And then finally, we did a phone call at the first working day after completion of the neonatal period, which was at the end of 28 days of life, to record the late anomalies and post-discharge deaths. So we will be talking about this as the day 29 call. Before we started, we really needed to be very sure about one thing. Can lay health workers effectively screen for anomalies? And fortunately, we did have the answer to that, because we implemented an infant male circumcision program in Pakistan, which has been published about 7-8 years ago in the WHO bulletin, where we set up a large cohort of health worker conducted in screened and conducted circumcisions at a public sector facility in Karachi, and we followed those newborns for a variety of outcomes and complications and so on. But as part of that bigger cohort, we looked at a 6-year experience to see if our health workers could reliably screen for genital anomalies prior to performing the circumcision. And yes, they were very, very effective. They were achieving high concordance rates with diagnoses made, evaluations done by pediatric surgeons. There were false positives, but we believe that the entire crux of health worker training should be to err on the side of safety. There is a risk of overdiagnosing and overburdening the system, but we cannot have health workers miss out, and that forms a recurring theme in the way we design our curricula. And this was obviously very impactful, not only for preparing a model that could be scaled for a country where 3.3 million male boys require a circumcision for cultural and religious reasons every year. But then it also had an impact on allowing us to be confident that health workers from the community could be trained to reliably screen for anomalies, allowing us to expand that same thought process to a broader group of external birth defects. So with that confidence in hand, we started to train them. And these are slides that I have borrowed from Shazia, and this really forms her master's thesis. So we had classroom training, we had on-site training. The trainers included health professional educators as well as programmatic implementers, pediatric surgeons. We had a psychologist come in to talk about how to handle parents at a very critical time for the family. And the trainees were health workers. They were dedicated to newborn screening because we realized that the frontline nurses and doctors are often changing on shift patterns, on rotations, overburdened, not very good at recording data. And this was really a modeling study, and therefore we required our data collection and our screening to be very robust. And therefore we had dedicated health workers that we trained for this purpose. They were women with 10 years of formal education, able to read and write basic English, and they had to be familiar with mobile phone use, which is really not a big problem at all these days, regardless of which community they're coming from. And they were paid training stipends, competitive salary, they were given overtime. And I think that is very important. We think that while we would love to work for good salaries in our universities and hospitals, but health workers should do it for the love of humanity. And that really is not a fair assumption. So they were well trained and they were compensated well. I won't go into the details of the training curriculum, but also I do want to emphasize that they were taken through a testing process. And again, this was a very robust process at the end of which they were certified. And this has been written up and now is published as a peer-reviewed journal article in BMC Medical Education for those of you who want to do a deeper dive into that. And that brought us towards the program implementation. Now, this is going to take a little bit of an understanding, so I'll take you through it at step by step. So we've already talked about the training of health workers. In addition to classroom training, we also provided on-site supervision for the health workers. Excuse me. And that was essential because the transition from classroom to real babies took some mentorship. And they were carefully guided by our program managers and program leads on site. 3 facilities. These are names of 3 of the highest birthing volume centers in Karachi in the public sector. Excuse me. Collectively, over 25,000 deliveries take place here annually. And we had health workers who were screening neonates for external congenital anomalies, data collection and REDCap. And once an anomaly was identified, there was a care helpline. Our acronym was the Congenital Anomalies Registry helpline that was always manned by a senior member of the team that could provide either diagnostic guidance or help with referral guidance to the health workers if they weren't sure. The family was counseled by the health worker and referral advice was provided. We'd done a service mapping to understand what facilities were available in the same hospital, in other partner hospitals, and within the larger city facilities that were available. And then finally, the health workers made a follow-up call on day 29, as I had mentioned earlier. So what we found was this. Over 25,000 deliveries, The health workers were able to screen for over 18,000. And the reason for the gap was because screening was initially started in the daytime. We missed some of the nighttime births. And sometimes there were holidays. It was impossible to provide staffing on the Eid holidays and so on. So we really managed to screen 73% or 74% of all the births. Very few refused consent, and the remaining were those that were born out of staffing hours. Of these, 96% were live births, a very large proportion of stillbirths. NLDs are neonates that were live at the time of the mother's discharge from the hospital. That means they went home with the mother. And we've used that criteria instead of a 24-hour or a 48-hour time because the time that the baby stayed in hospital varied a lot from 4 hours to 4 days. So we used that criteria. Early neonatal deaths were removed. The follow-up was done. 70% of those screened were contactable, whereas about 30% were lost to follow-up. And at the end of the neonatal period, 98.2% of the newborns were alive, whereas 1.8% of them had died, or 223, between discharge and day 29. So let's look at what was happening. We found 334 major anomalies. I'll focus on the major anomalies in the interest of time. So there were 390 major anomalies in 334 newborns. And the commonest really were clubfoot. A lot of this was the safety net because this was one area that the health workers found particularly difficult to identify correctly, whereas the others were easier to identify. Now, if we look at this and look at the neonatal deaths, what we're seeing is that neonates with anomalies were over 3 times more likely, or just under 3 times more likely to die within the neonatal period as compared to those without anomaly. And this is to a large extent influenced by the major anomalies. So almost a quarter of all newborns with a major anomaly did not survive beyond the first 4 weeks of life. What was most startling was that this was in urban Karachi, and this was in facility births, in a group of people or families who already had documented access to care. And that was what was very worrying. By way of comparison, all 8 of 8 gastroschisis newborns died, 7 within the neonatal period, and the 8th was literally a couple of days after. Anorectal malformations, which have less than 10% mortality, often associated with comorbid conditions. Over a third of them die in the neonatal period alone, and a fifth of orofacial clefts died within the neonatal period. And this is pretty jarring for us to have. The numbers shocked even my expectations. We did a quick deep dive into looking at this 223 cohort more, and we were able to contact 146 of these 223 deaths to do a verbal autopsy. We were able to establish the cause of death in 71, and the total deaths in those with birth defect was over twice that of those without birth defects. And this is obviously what is making the most impact on that figure. Besides this, kids with birth defects die of pneumonia, diarrhea, and sudden infant deaths as well. And these were the most common anomalies in the mortality group. So our key learnings from this, our key takeaways were that a health worker-led model is feasible. Prevalence data, for the first time, we had robust prevalence data for external anomalies in Pakistan. And despite screening, despite referral, despite being in urban Karachi, the neonatal mortality was very, very high. We don't have baseline figures, so we can't say if the screening or the referral helped or didn't help. But regardless, this is a very high figure. So what we realized is that screening does not necessarily translate into survival. And why is the neonatal mortality so high in urban Karachi? Now I'm going to pause over there and for about 5 minutes, and I hope not longer, go quickly into a deeper dive of three sub-studies that we did. We looked at clubfoot screening, and this was really to understand how we can improve health worker training. And we saw that there are three distinct phases. So there's a first phase where prevalence is pretty much under 1%. And this is higher than reported prevalences because we're looking at screened positives and not diagnosed positives. And then there is this jump to 4 times what you would expect in the middle of the study period, and then we normalized it. So what happened here? In phase 1, we had very close supervision. We had specialist reviews taking place. Every single newborn was photographed and then reviewed and then reclassified by in collaboration with the health workers. The moment that supportive supervision finished, they became nervous. They didn't want to miss anything. They started overdiagnosing. And that's when we went back and realized that there was a spike because we trained them through static visual aids. We then made a video which showed the way positional clubfoot can be differentiated from true clubfoot. And after that was done, we got back to the baseline rates again. So this was a small snippet to show how this iterative process of refining the curriculum, looking at the data, and correcting yourself is very important. Secondly, I'll talk a little bit about the cleft nutrition and survival. We followed a longitudinal cohort of these cleft kids up till 12 months of life. 1 out of 45 was a stillbirth. 1 died in hospital before discharge, 9 during the neonatal period, and overall 20 newborns, excluding 1 stillbirth. That's 19 live births died before the end of the first year. And this is a much higher prevalence than previously recorded, possibly because when you look at those babies coming into facilities for cleft care, you're missing out those that never make it to facilities. Infants with OFCs are at a higher risk for malnutrition and infection, and it is only the survivors who actually make it to surgery. And then we did a bit of a deep dive to try and understand what was going on. And then again, this was so upsetting because high rates of malnutrition, significant barriers to care. While a lot of NGOs are providing cleft surgical care, there is very little nutritional support, NICU support, pneumonia treatment interventions available for these babies. And they have a miserable time trying to get the care that their babies need. And therefore, context-specific pathways must be made available if we are to improve this. Last minute or so in this last deep dive to understand the spina bifida spectrum disorders. Again, very common, very high prevalence, and almost a third don't make it beyond the neonatal period. This is excluding the encephalocele and other cranial neural tube defects. Identifying spina bifida occulta is challenging for health workers, and there were no referral guidelines that were contextualized for our setting. So our neurosurgeon colleague who was advising on this condition he realized the problem, that there was no referral guideline and there was no consensus. So he developed a modified Delphi technique study and got 26 neurosurgeons to provide responses and then developed contextualized guidelines that were adapted for low resource settings that we have then continued to use after that. So I will try to go over this in a couple of minutes. I probably will not do this justice, but I do want to talk about the study. And if there is an interest, I can take this up in the Q&A a little later. We wanted to understand why these infants are not getting the care they need. What's happening? So we did a mixed method study where we wanted to identify the caregiver-reported barriers and facilitators to accessing care, and to explain and contextualize these findings through a focus group discussion, qualitative inquiry, and then to integrate these results. We did a quantitative survey for 106 caregivers, and the focus groups, there were 4 focus groups in all, with 23 caregivers. And this occurred soon after the end of our surveillance year. We chose 7 to 9 month old infants at the time of the survey, so that since the 6-month cutoff was one of the commonest referral cutoffs in our guidelines, and then this was really, I'm just going to show this as a mixed methods strategy that we used, where we used a quantitative data analysis and qualitative data analysis, integrating the findings. And then we looked at 6 domains across the validated framework that we use, the Penchansky and Thomas framework, where we looked at accessibility, availability, acceptability, affordability, adequacy, and awareness. And then we added a 7th one, which was not there in the previous reported framework, and that is affiliation or social embeddedness, because we found that this one factor or this one aspect influences everything. You know, families in our part of the world live within communities. The family accompaniment, the financial support, family members and neighbors helping look after older children while parents take the newborn for care, was a huge factor in the ability to access care in our setting. And we realized that families face significant challenges despite the availability of services at facilities, and a systems approach, which may not necessarily be designed for OFC or neural tube defects, but is required to strengthen surgical platform and efficiency. The pathway of coordination, referral, family support matters, because the integration of care is essential to achieving good outcomes, and social embeddedness or affiliation is a key factor influencing access. And so we realized access is not automatic. And the question remains, how can recommended care that we refer or advise translate into received care? And that's really something we don't have the answer for. We did, however, use an opportunity to get the pediatric surgeons across Pakistan to assess the commonest structural congenital anomalies using 3 criteria: burden, how common are they, how feasible is it to intervene. It doesn't make sense to prioritize critical congenital heart disease in a country where there is no facility to look after or intervene or operate on children. And the potential to avert mortality, morbidity, and disability were also considered. And this is what our pediatric surgeons chose in the first round, the top 11 conditions that we then took into a second round. And these are the 3 that we were able to achieve a consensus on. And our current focus is to try and see if we can develop care pathways for one or more of these conditions as a way of testing how an integrated care pathway can impact outcomes in our setting. That's it from my end. I hope I have not exceeded my time too much. No, just about half an hour. So Dan, over to you and to all of you.